Na barabara kabisa mtazamaji, karibu tena kwenye awamu nyingine ya kipindi cha Shina la Upeo, ambapo tunaendelea kufahamisha kile ambacho kinajiri katika maeneo tofauti tofauti. Lakini kwa sasa nafahamishwa kwamba tuvuke moja kwa moja hadi katika jumba la afya, ambapo katibu mratibu katika Wizara ya Afya Rashid Amana anazungumza kuhusiana na makali ya virusi vya corona humu nchini.
Kana uwe COVID positive, hakuna kitu ya kuogopa, mujitoe, ogope kuja mbele, kujitoa kupimwa. With regard to our COVID-19 situation in the country today, we have tested 2,293 samples, out of which 62 people have tested positive for COVID-19. This now brings to 1,348 the number of those who have so far tested positive, and the total number tested so far stands at 64,264. Out of these positives, 59 are Kenyans and 3 are foreign nationals. In terms of gender, 45 are male, while 17 are female. Age-wise, range from between 6 years for the youngest and 64 years for the oldest. The positives are spread in the counties as follows: Nairobi with 23, Mombasa with 16, Kwale 8, Kiambu 6, Kajiado 6, and Kitui 3. The cases are distributed in the sub-counties as follows. In Nairobi, Umoja at 6 cases, Kibra 6, Isli 3, Dagoretti North 2, Langata 2, Westlands 2, Starehe and Embakasi East, each 1 case. In Mombasa, the cases are from Changamwe 9, Nyali 3, and Vita 1. In Kwale, the cases are from Msambweni 4 and Lunga Lunga 4. In Kiambu, the 6 cases are from Lari 5 and Ruiru 1. While in Kajiado, the cases are from Kajiado Central 4 and Kajiado East 1. The 3 cases from Kitui are from Miambani in Kitui Rural. We are glad to inform you that we have, as of today, discharged another 3 patients who have recovered from the disease, bringing the total number of those who have recovered to 405. We thank our healthcare workers for the good job done. Thank you. Allow me now, you can see today we are joined at this press statement by CS Macharia of Transport and CS Aden of East African Cooperation. And they are both here to make some statements to the media. Let me invite CS Macharia now to make his statement.
Thank you very much, CS Rashid. I'm here specifically to talk about the transport corridors which we have, and also the border points. Because, as you know, in terms of trade and in terms of the transmission or containment of this virus, our transport corridors are very, very, very important. And with that also comes the issue about transport logistics. And so we have made a lot of progress in terms of collaborating with our partners on the key entry points. Many of you knew recently that there was an issue which we had at Namanga, whereby the trucks, the cargo trucks from Tanzania side were not coming through, and vice versa. And the reason was because there was a bit of disparity until last week with regard to the testing protocols. And so last week, on Friday, the 22nd of May, myself, in fact, together with CS Rashid and other senior government officers, including three regional coordinators: regional coordinator of the coast, regional coordinator of Nyanza, and regional coordinator of Rift Valley. We went Rift Valley. We went to Namanga to meet our counterparts, to meet the 5 regional commissioners on the side of Tanzania, and by the end of the day, the Minister for Transport. We had very fruitful discussions and very good outcome, because by the end of the day we signed an MOU confirming that we had agreed on the testing protocols. For us as a country, we insisted that anybody coming through our borders had to be tested using the agreed international WHO standards, which is what they call the PCR protocols. And so that was agreed, and that's why from last week on Friday, the trucks carrying cargo, essential services, started flowing through the border with Tanzania. Many of you now, in particular Malaba, where we have a very long queue of trucks. This is not because of differences. We've been full of trucks. This is not because of differences of testing protocols between us and Uganda, because we've been following the same protocols in terms of medical process of testing the virus. But it was because, when I say inside, it's only a few, about 3 truck drivers who went and blocked the entry to the border, thereby creating a queue of up to 50 kilometers at the Malaba border. This, we said, is unacceptable, and today, as government, we have put measures in place to open the border, and we have told those people who are causing problems that you do not have to drive towards the border. If you feel you have grievances in terms of you entering Uganda, then don't leave your point of departure. Don't collect cargo in Mombasa, don't collect cargo in Nairobi, heading to the border only for you to go there and cause confusion. That we said we will not accept, and that's why we have identified, narrowed down the people who are causing these problems, and that matter is being dealt with as we are speaking. As you know, Uganda, through Malaba, is the entry point to the Great Lakes. And the Great Lakes, they account for about 30% of all the cargo which come through the port of Mombasa. And so we cannot be having all these investments which help in our development, and then we have a few individuals causing trouble. What you have said before any truck driver leaves their point of departure, they must get the COVID-free certificate, the COVID-19 free certificate, 48 hours before commencement of the journey. With that, upon getting to the border, you don't have to wait. It will be an express way. And we have engaged our colleagues, and my colleague Aden Mohammed, who is the EAC minister, will be talking about that, to make sure that we have seamless interaction with our partners across East Africa. We like to keep our corridors open, because trade is what will bring development to our country. And so let me take this opportunity to invite my colleague, Aden Mohammed, to discuss about the broader issues about East African cooperation.
Thank you very much, Waziri and colleagues. I think the issue of the challenge that we have in Malaba border is something that is probably one of the most immediate and serious issues that we are dealing with as government. As you know, our trade within the East African community remains a critical aspect of our economy's success story. The Mombasa port serves the whole of the region beyond Uganda into southern Sudan and DRC, and the importance of Malaba-Busia border is quite critical for us. It is already bad enough as a result of Corona for us to have experienced the delays that we suffer on the corridor, because if you think about it, pre-Corona days, it would ordinarily take 3 days for a driver to drive from the port of Mombasa to Kampala and back. And as an introduction of the tests and COVID issues came up, that time doubled. And you can imagine the amount of delays and the economic consequence of that has been quite serious. Now, as if that is not enough, then we have had issues that have developed, largely a creation of our own truck drivers that has caused a 50-kilometer long delay of trucks that is now becoming a security threat. And as my colleague C.S. Macharia mentioned, we took a decision as government this morning to really exercise all that is within our means to make sure that that corridor is cleared. And I'm pleased to say that whilst we have been here, the 4 trucks that have been blocking the entry into the Uganda side of the border have now been cleared, and clearances and movements of people, of trucks, have already started moving. We expect that exercise to take probably 4 to 5 days to clear. As that exercise is going, we have asked our colleagues, all the stakeholders at the port, at the border port of Malaba, to work 24 hours, whether it's immigration, port health, revenue authority, and our security colleagues, to make sure that this clearance starts now and we get this backlog behind.
My colleague C.S. Kagwe has made it extremely clear that all our truck drivers must get 48 hours before they start their journey the tests and the necessary certificate, which is being respected by our colleagues on the Uganda side. And we are aware that there have been issues raised by our truck drivers, especially once they cross onto the Uganda side of the border. We have had our Kema Kilonzo, who drove from Kampala to the port of Malaba yesterday to actually inspect some of the stop points that have been the main cause of concerns for our drivers, where complaints about lack of adequate facilities and improper sanitation facilities have been reported. Of course, we will not expect first-class facilities. It is challenging times, but it is not as bad as people have described, and that have caused the blockages that we have seen. We've also had complaints from our truck drivers that testing that is being done at the border point by Ugandan authorities is painful, and that the necessary swabs that are being done is quite painful. We urge our truck drivers to do tests in Kenya. Once you have the certificate, you don't have to be subjected through that painful exercise that you are complaining about. So it is a time to actually exercise patience on everybody's side. This is an unusual time. People's emotions can run high. But what I think is not acceptable is to block the entry point of Uganda through the vehicles that we get from Mombasa entering into Uganda through the port of Malaba. That is something that will not be accepted. Whilst we endeavor to deal with the grievances and issues that have been highlighted by the drivers, all arms of government are collaborating.
Port of Busia, which is an alternative route for people to use. We also have the area through the border of Loakaka, where vehicles coming from Uganda have also been using to come back as a way of easing some of this congestion. And so I think, unlike some of the issues that we've had to deal with before, which was as a result of lack of understanding and having a common view by EAC member states, this issue of Malaba is a unique one in that it was a creation of our own people who decided to block the road so that their grievances are being heard. And we will work jointly with them, and we just urge everybody to be patient and make sure that we act within the law and what is responsible as we all try and overcome this issue of corona pandemic. Thank you very much, ladies and gentlemen.
COVID-19 curve in the country for the next 30 days. My second question is, you've talked about crafty Kenyans who are giving wrong contact information. So far, how many Kenyans gave wrong contact information who turned negative that you are still tracing where they are despite their positive status? And my last question is from Changamwe. We have information that a positive patient has escaped the hands of the government. How far is the chase of that positive patient, if you are aware of the same? Thank you.
Next, please keep it short. Okay? Yes, thank you. My question is to Dr. Patrick Amoth. In regard to Leto's question, you are depending on a modeling where you said that 10,000 cases will be recorded by the end of April, and now you say the peak will be in September, where we will start recording 200 cases daily. What sufficient data are you using, and how is it underpinning your modeling in terms of the projections? And to the second question, the CS Mohammed and CS Masharia, you have mentioned the WHO standards in terms of the testing done in Tanzania and in Uganda. What measure are you using to depend on the testing capacities of the two countries when one country is not adhering to the World Health Organization guidelines, and then in Uganda there is largely media censorship where people are struggling to see, hear and read what the Ugandan authorities are saying? So what is the gauge and the measure of the numbers coming out of these two countries?
Purity Museo from KBC. My first question is how you're able to tell whether the cases of COVID-19 are increasing, given that every single day you are doing different number of samples. For instance, today we had over 2,063 people tested positive. Yesterday we tested 1,000 and something, and 22 tested positive. So how are you able to tell Kenyans that because we have these samples taken, is there a way we can have a constant samples tested in a day so that we are able to know whether the numbers are increasing or not? And then number two, you talked about the government offering free testing, quarantine and treatment for COVID-19 patients, but today there are two patients at KU referral facility who to go home, but one has a bill of 136,000, the other one going to commence for these patients.
My name is Graham Kajina. The question is about the WHO on suspension of the chloroquine. The clinical trials for the drug.
I wanted to ask, my first question is, are we truly prepared to lift the lockdown as a country? Whereas the Ministry of Health has complained in the past that there are issues of indiscipline amongst Kenyans, with some of them using crafty methods to cross, different border points and even attending church services which are banned by the government. My second question is, what has led to the high numbers that we're seeing in Langata, which is also becoming an area of concern, and what is the government doing about containing the situation in the area? Thank you.
And let me start off by answering those that are directed at the ministry, providing a response. I'll also ask Dr. Amoth to come in and back up with some figures. Stephen Latoi You asked about the modeling data that we are using.
Next 30 days or so. I'll allow Dr. Ahmad, when he comes to the podium, to address that and the following question also, which was on the modeling. But I want to say one or two things about modeling. You know, modeling is a procedure that helps to guide us on what we may predict, what we might be able to see given the circumstances that we are facing. And any model works on partial data, but it also works on making assumptions about certain things. Therefore, no model will be perfect because it will not have all the hard data that you require to be able to make an accurate prediction. Models will give you an idea and give you some level of prediction. Those predictions will you know, whether those predictions come true will depend upon the assumptions that are made. And different models have made different assumptions. But as we move forward in this pandemic, and the whole globe experiences this pandemic, some of these data become hard data. And therefore modeling then tends to improve with time as you move forward. Dr. Ahmad will talk about that, but we expect that our level of modeling and prediction will improve with time as we move forward. I think you recall that earlier on we had talked about 10,000 peaking. We are now talking about 2,000 a day or so, perhaps late in August or September. Dr. Ahmad will address that issue. In terms of the wrong contact information, how many are there? I think for us to raise it here and to appeal to Kenyans that they need to give us correct information, I think it is a matter of concern because we are seeing quite a number of people who have been tested, but we are not able to trace them. And so that is a concern because once they are tested, especially if they turn out positive, it's extremely important that we are able to get these people who are positive and to be able to isolate them and provide them the treatment they need and to contain them so that the virus does not spread. So it remains an issue of concern, and we want to continue to appeal to Kenyans that they need to present themselves. They need to give the right information that we can be able to contact them when the results are out. The patient from Changamwe, I haven't heard about that, but perhaps Dr. Ahmad might know something about it. The patient whom you say escaped facility in Changamwe and is positive. Now, there was a question that said, how do you know, how can you tell whether the COVID numbers are increasing, given that we are testing different numbers every day? Our testing capacity, as I said before, is largely determined by the resources and reagents that we have for testing. When you see us increase our testing level, it's because we then have sufficient kits to be able to do the level of testing we're doing. And you will note that in the last week or more, we have been testing 2,000 and over a day. That's a fairly large number. But you also know that when community transmission of the virus has established itself, then the number of positives that you are going to unveil is dependent upon the scale of testing that you do. So clearly, the more testing you do, the more likely it is that you are going to unearth more positives. That is expected. However, how does this information then help us? This information helps us because once we have been able to concentrate in certain areas, depending upon the the risk maps that we have generated, and we see good numbers there, then we know that that's an area of high risk that requires some level of action or containment to reduce transmission of the virus. So it does inform us on the interventions that we will take to be able to contain the virus. On the matter of treatment costs, treatment testing costs, but largely treatment and quarantine costs. I think we have been putting out this message for quite a while now to the public that if it is a public facility and you are isolated or treated in that facility or quarantined in that facility, those costs are to be met by the government. Now, whether there are some facilities that are still putting up invoices. I don't know about that, but clearly KU is a public facility. The government position is that public facilities do not charge patients. So I'm sure that that case that you mentioned will be addressed. The Standard talked about the clinical trials that are going on, the solidarity trials which are sponsored by the World Health Organization on chloroquine, and whether we're seeing any of the clinical data that is being reported from some of these trials. What I can tell you is that Kenya as a country, we have signed up to be a part of these solidarity trials. And one arm of these solidarity trials is to evaluate the effectiveness of chloroquine when it is used as a treatment for COVID-19. These trials have not yet kicked off in Kenya because we have a process and a procedure of approving clinical trials. That process is ongoing and will be completed very soon, after which we will be able now to recruit patients who are in these facilities and then provide and put them into this study so that we can be able to determine whether chloroquine works or not. So that is the position we are at now. Some countries have moved forward in the solidarity trial. They had signed up earlier. They have been able to move forward and they are recruiting patients, and some level of data is coming out. But the solidarity trials are meant to collect as much information as possible across the globe. In fact, I think there are more than 40 or 50 countries that have signed up to do the solidarity trials. With that large number of patients being recruited, I think the data that comes out at that time, that's the kind of data that we can certainly say, indeed, either the chloroquine works, or it doesn't work, or it has these side effects, and so on. So that will come out once the trial is over in all of the countries that have signed up to be part of the trial. I think that's it for the questions that were directed to the ministry. I will ask the CSs to respond to their questions, and then we'll have Dr. Amo come up and wrap up with his responses.
Yes, I think there was a question which was asked about, if I got you right, about the credibility, or how do we get assurance that what we are getting from these countries meet the standards required. You see, if I give you an example as to what we discussed with Tanzania, we discussed and agreed and put it in writing that those tests will be done in WHO accredited facilities. So even here in Kenya, we know those facilities where they are, the likes of Cambridge, for example. So even for these other countries, WHO will be accrediting certain facilities to make sure that they can comply or align with international standards. And we also get additional comfort because if we recall, through the EAC mechanisms, we had donations of mobile laboratories, I think from the Republic of Germany. These laboratories are placed in these various countries, and therefore the test being done in Tanzania with that laboratory will be the same as done by us, the same done by these other countries like Uganda. And that gives you extra assurance that what is coming out is indeed what is required. I think there was an issue about lockdown, and all I can say is that this is a matter which is continuously being reviewed by the respective committees which report to the president. And then thereafter, as you know, the president as head of state, he does give regular and progressive pronouncements with regard as to what will happen. So all I can assure you is that that process of review is a continuous process, and therefore, as and when decision will be made, they'll be escalated, and then the appropriate pronouncement will be made by the head of state.
Waziri, thank you. And let me add on to that, Waziri, also for your own information and for the media. I want to inform you that the mobile lab which we took to Namanga is already in place. It is already functioning. And as of today, it received about 46 samples from the point of entry to be tested with a turnaround time of about 5 hours or so. So what we had said is happening, and we hope that with this lab present there at Namanga, we should be able to deal with now the flow of the truckers across the border. In terms of the protocol for the test that we are using, and the Waziri has talked about it, it's a WHO recommended protocol, and the WHO recommended protocol standard for diagnosis of coronavirus. And I want to make a distinction between diagnosis and picking up antibodies in blood. The diagnosis of coronavirus, where you want to demonstrate that the virus is actually present in the body, can be done by one test, and that is a molecular test called the reverse transcriptase PCR test. That is the standard that WHO has recommended for diagnosis of coronavirus, and we have agreed amongst the East African community members that that is the standard we shall use. So I think there is comfort knowing that we shall be using the same test to be able to issue the COVID-free certificates. Dr. Ahmad.
Thank you, CS. Thank you, Waziri Adan, Waziri Macharia, for joining us today. I'll just add a few things on what has been articulated by the CS. In terms of the modeling, of course, as Waziri has indicated, modeling is basically trying to project numbers or cases of a specific disease at a particular time based on data that is available. And modeling is not exact science. And I want to remind you that when we gave the figure of 10,000 for April, that was based on the fact that we would undertake no intervention. But remember, we did a lot. We closed schools, we closed churches, we stopped all gatherings. Then we also had the curfew in place. And then, of course, we ramped up in terms of behavior change communication for infection prevention control. This significantly flattened our curve, and therefore the numbers, even though they increased, they didn't increase exponentially so as to overcome or overrun our health facilities. Number two, yes, we can do modeling for 30 days, but it would make no sense to be able to project over a long period of time. In fact, last night, WHO gave a modeling of the disease pattern for COVID-19 in Africa, and if you look at the figures that they gave vis-a-vis what they gave 2 or 3 months ago, the numbers have drastically decreased. So let's not be fixated with the numbers that if Dr. Ahmad says you are going to have 3,000 cases in August, then that must come to happen. No. It is based on the measures that we put in place, the behavior of the population, therefore stopping transmission. And of course, that target is not set there to be achieved because it's a worst-case scenario. And when you plan with that modeling, you plan with the worst-case scenario so that you are properly prepared in terms of the numbers of human resource, in terms of the PPEs that require, the testing capacity, and everything else you require for containment. It is difficult to be able to test a given number of persons per day. One, testing is voluntary. We cannot put a gun to your head and tell you that you must be tested for COVID. Then testing is happening all over the country. So it will be very difficult to be able to say County X give us this number, County X, Y give us this number. This will just lead to falsification of the numbers, and it will not be informative. There's a journalist who talks about the actual numbers. Remember, on Saturday we usually have a meeting with you upstairs where we show you the graphs, the AP graph, which tells the total number of cases on a daily basis and vis-a-vis the total cumulative cases over a period of time. And if you remember how that graph looks like, it is a gradual increase in the number of cases, which we are happy about because it means our healthcare system is resilient enough to be able to respond to, and then we don't have surges in terms of very many patients coming to the facility. We are also equally happy because the initial cases of community deaths that we are witnessing in Isili, in Old Town, have now become a thing of the past. So it means that the message is sinking down. Regarding the Langata cases, many of those cases actually come from the informal settlement in Kibera. And you know the challenges that you'll face. One is high population density, therefore making physical distancing a very tall order. Number two, in terms of infection prevention control measures, availability of water and sanitation facilities is also compromised. So it is up to us, together with you, media as custodians of the people's information, to be able to continuously articulate these issues to the public, whether they must maintain social distancing, continuously wash their hands with soap and water, and of course use sanitizers where available. Finally, on the chloroquine, hydrochloroquine, yes, that was stopped because this was published in a very reputable journal, The Lancet, and it clearly showed that those who are on hydrochloroquine or chloroquine treatment were at a higher risk of death. That is about 37%, and 145% risk of developing abnormal heart patterns or arrhythmias. If you want further to look at hydrochloroquine together with the antibiotic azithromycin, the risk was even higher. The risk of death was much, much higher, and the risk of having abnormal heart patterns or arrhythmias was 415%. So clearly, based on that science, it would not be prudent to continue with that arm of the trial. But the other arm of the trial, the Solidarity trial, that includes remdesivir, will continue. The arm that uses Kaletra, that is ritonavir, lopinavir, will also continue. WHO is going to review this data based on safety and will revert back to us. But of course, the drugs can still be used for other conditions for which they are registered. That is mainly autoimmune diseases like rheumatoid arthritis, systemic lupus, and porphyria cutanea tarda. Thank you.